Sphenopalatine ganglion (SPG) blockade has been utilized for decades in treating various types of headache and facial pain syndromes, sometimes yielding promising outcomes, but unfortunately, frequently resulting in failed treatment results. However, providing this procedure in a simple, fast, effective, and affordable manner has been difficult to achieve. The SphenoCath addresses all of these challenges. In the next few moments, you will see how the SphenoCath delivers rapid, accurate placement of anesthetic to the sphenopalatine fossa, usually resulting in blockade of the sphenopalatine ganglion. In addition, pooled injectate in the sphenopalatine fossa results in direct egress of the injectate into the petrosal or Vidian canal laterally to the pterygopalatine fossa, which subsequently anesthetizes the pterygopalatine ganglion and the maxillary branch or trunk of the trigeminal ganglia, frequently called V2. These and other important nerve fibers contribute to the central autonomic and sensory components of headache pain. This sphenopalatine circuit can be blocked without needles and without pain. Accurate placement of the local anesthetic can be accomplished in minutes and provides delivery of the anesthetic to the entire sphenopalatine circuit, V2, producing outstanding results. The following step-by-step approach demonstrates how healthcare practitioners can successfully use the SphenoCath to rapidly accomplish sphenopalatine circuit V2 blockade in the management of migraine and other trigeminal-vascular pain syndromes. After explaining the procedure and obtaining informed consent, inspect the SphenoCath and packaging. Pull the catheter out of the package and inspect the catheter. Verify that there are no rotational defects by ensuring that the deployed inner catheter is spatially aligned with the directional indicator on top of the hub. Retract the inner catheter by pulling the gray and purple hubs apart. Prepare a tray before beginning the procedure, including a 5 cc syringe full of 2% lidocaine for the sphenopalatine circuit block. Lidocaine gel should be used to lubricate the catheter prior to insertion into both nostrils. For patients with sensitive nasal mucosa, pre-medication with 2 or 3 gentle passes per side using a cotton-tipped pledget soaked in viscous lidocaine can be very helpful. It allows the practitioner to feel the course and provides effective lubrication and anesthesia. In patients with obstructive anatomy or congestion, atomized lidocaine or Afrin might be an appropriate pre-treatment as well. The procedure is done with the patient lying flat on their back so that the medication can easily be delivered to the appropriate location. Placing a pillow under the shoulders and resting the patient's head on the procedural table will extend the neck, creating an easier point of access for the practitioner and maximizing anesthetic delivery to the superior posterior nasal cavity. To ensure accurate skin temperature measurement, the areas across the inferior aspect of the zygomatic arches should be cleansed of makeup, skin oils, or other substances. The temperature strips should be placed at the midline position of an imaginary line between the midpoint of the tragus of the ear and the inferior aspect of the lateral nasal flare. Validation of procedural accuracy is confirmed by a 3 to 5 degree increase in patient's skin temperature in the V2 dermatome. Documentation of the baseline temperature must be carefully noted and recorded prior to initiation of the pre-medication procedure. Typical pre-procedural skin temperature ranges from 92 to 94 degrees. If the practitioner elects to use either or both of the pre-procedure anesthetics, atomized or viscous lidocaine, this is the time to do so. Before beginning the procedure, inform the patient that the lidocaine may have an unpleasant taste. It is important to advise the patient that if they move their head or sit up during the procedure, it will negate the effectiveness of the procedure. In preparation for inserting the SphenoCath connected to the lidocaine syringe, lubricate the distal 1/3 of the device. Make sure the inner catheter is in the retracted position and the direction indicator on the hub is facing towards the ceiling. Prior to actual insertion, remind the patient that they may experience a brief, mild twinge of discomfort when the catheter comes in contact with any part of the nasal sinus mucosa. This is a normal response and should not cause concern. Inform the patient that you're going to gently insert the SphenoCath into their nose. With the directional indicator pointed towards the ceiling, the SphenoCath is inserted through the nostril and nares. Using the non-dominant hand as a guide and anchor is very helpful. Gently place the tip of the middle finger on the tip of the nose and let the catheter glide between the tips of the thumb and forefinger. Advance the catheter gently toward the bridge of the nose. Once the catheter has passed through the nares, the practitioner gently rotates the directional indicator on the hub medially, approximately 8 to 10 degrees toward the midline of the nose. Once this is accomplished, the entire catheter is adjusted to become parallel to the bridge of the nose and is gently advanced superiorly and anteriorly until meeting resistance with the superior nasal bone, exerting care to avoid contact with the middle turbinate. The practitioner will feel a definite stop when the catheter contacts the superior nasal bone. Care should be taken to make that contact as gently as possible, as it will likely be the only truly uncomfortable part of the procedure for the patient. When first attempted, this procedure may seem counterintuitive to some practitioners compared to other transnasal insertions, as it does not involve esophageal or tracheal targeting such as NG tube placement or nasal tracheal intubation. It is critical to the success of the procedure that the medication be injected above the middle turbinate and below the superior turbinate. As soon as the practitioner feels the stop, the catheter is withdrawn 1 centimeter and anchored in position with the hand that is touching the tip of the nose. This will allow the practitioner to adjust the position of the outer sheath held between the thumb and forefinger while the inner catheter is advanced. The inner catheter is then advanced into the extended position by pushing on the purple hub with a gentle, equidistant push-pull motion to keep the inner catheter directed above the middle turbinate. During deployment of the inner catheter, it is important to move the gray hub and purple hub simultaneously in an equal distance towards each other. Now the SphenoCath is in position to inject 1.0 to 1.5 cc's of 2% lidocaine. At this point, inform the patient that you are now delivering the medication. A brisk, slightly pressurized delivery of injectate enhances procedural efficacy. If the patient sneezes or coughs, pause until they are done. Retract the inner catheter by separating the hubs. Pull the entire device back at least 1 centimeter. Then advance the device until nasal bone resistance is felt as previously instructed. Withdraw the catheter 1 centimeter. Deploy the inner catheter, and then begin injection when the patient is ready. If the head is appropriately tilted back and the catheter is correctly positioned, little or no lidocaine should run down the throat until after the procedure and the patient sits up. If the patient feels a significant amount of lidocaine run down the throat, the catheter has likely been placed in front of or below the middle turbinate, which is too low. In this case, make sure the patient's head is tilted far enough back. Withdraw the inner catheter to straighten the device. Reposition the catheter to achieve a steeper incline relative to the bridge of the nose by lowering the hub and syringe closer to the patient's lips. Make contact with the nasal bone, withdraw 1 centimeter, deploy inner catheter, and repeat injection of 1 cc of 2% lidocaine. Once the medication has been delivered to the correct location, inform the patient that you will now remove the catheter. Prior to removal of the catheter, fully retract the inner catheter so that the device is perfectly straight upon removal. Once removed, instruct them to remain in this position while the procedure is repeated on the other side. Before proceeding to the other side, be sure to liberally apply additional lidocaine gel to the outer catheter. The practitioner begins to assess the physiologic markers of successful procedural application. These include 1. Tearing from the lateral canthus, 2. Conjunctival redness, and 3. Most importantly, a 3 to 5 degree temperature increase as shown on the microcrystalline temperature strips. Documenting the temperature increase is essential to demonstration of a properly performed procedure. It will also provide proper billing-related validations. If the patient was symptomatic before the procedure and experiences significant resolution of symptoms, the biologic validation metrics are not essential for verification of procedural efficacy, but should still be documented for billing purposes. If, however, the patient was asymptomatic prior to the procedure, failure to demonstrate at least 3 degrees of temperature increase requires repeating the procedure on any side failing to achieve such a temperature increase. It is essential that the patient remain in the procedural position for at least 5 minutes following the second side injection of lidocaine. This will maximally enhance gravitational-dependent permeation across the nasal mucosal membranes and proper disbursement of injectate into the entire sphenopalatine circuit, V2. This procedure produces a parasympathetic overdrive, which results in a mild relative hypovolemia. The patient should be instructed to orally hydrate pre- and post-procedurally until they are urinating frequently, assuming there are no cardiac risk factors present. Additionally, they should be instructed to refrain from altering their baseline caffeine consumption for at least 72 hours and refrain from aggressive physical activity, including sexual activity, for at least 24 hours. In the past, sphenopalatine circuit blockade has been technically difficult for practitioners to perform and uncomfortable for patients to receive. Additionally, modern research has indicated that the sphenopalatine ganglion proper is only part of the entire sphenopalatine circuit, also called the central autonomic circuit. This circuit, along with the second branches of the trigeminal ganglia, V2, comprise the majority of the pain initiators for migraine, cluster, and TAC, also referred to as trigeminal vascular related pain disorders. The SphenoCath provides complete saturation to the entire central autonomic V2 circuit. Something new, something better. The first and only patented, originally conceived and developed device capable of administering sphenopalatine circuit V2 blockades. No needles, less risk, better results. SphenoCath.